Okay, so in this video, I'm just going to go over a little bit of the tidbits for the brain bank that are on this exam and haven't really covered yet. So they're not really related, it's just all what's going to be on the exam. So first I want to start with sideroblastic anemia. So certain things lead to sideroblastic anemia. It can be X-linked inherited, or you can alcoholics can get it, or B6 deficiency can lead to sideroblastic anemia. Also, like the TB drug, isoniazid, or INH, can lead to sideroblastic anemia. And also lead poisoning can lead to sideroblastic anemia. So basically, sideroblastic anemia, you have a deficiency in the protoporphyrin that makes up your heme for hemoglobin. And so if you have a decrease in your protoporphyrin in the mitochondria, then the iron that wants to bind with that in order to become heme, it gets accumulated outside of the mitochondria because it has nothing to bind with to make that heme. So you have iron molecules like outside of the mitochondria, and so that's what causes like a ring, and it's called ring sideroblasts. And that's just around the nucleus of the red blood cell, and you can see that with a Prussian blue stain. So it's important to know the formation of protoporphyrin that's affected by lead poisoning. So the reason why protoporphyrin is not being created is because lead affects two of the enzymes in the pathway that creates protoporphyrin, and I'm just going to abbreviate them. So lead will affect the ALAD and the ferrochelatase. So the first enzyme in the pathway for protoporphyrin is ALAS, and the next is ALAD, and then the last stage that creates protoporphyrin would be the ferrochelatase. So lead affects the second and the last enzymes in that pathway, so you'd have a decrease in the ALAD and the ferrochelatase in the protoporphyrin pathway affected by lead poisoning. So if you have lead poisoning, the signs you would see go with the acronym LEADS. So you'd see lead lines in the gingiva and in the long bones on x-ray. You would have encephalopathy, erythrocyte, basophilic stippling. So lead poisoning, think basophilic stippling in a red blood smear. A lot of question stems will talk about abdominal colic. So a stomach ache for a kid who lives in an old house with lead paint on the windows. Also anemia, sideroblastic anemia, because of the decreased protoporphyrin synthesis. So that can't combine with iron to make the heme, which can't combine with the globin to make the hemoglobin. So you'd have anemia. You'd also see drops, foot drops and wrist drops with lead poisoning. And then Suxamer is used for chelation for kids, and that's the treatment. So if you see kids with lead poisoning, you treat with Suxamer. Sucks to be a kid with lead poisoning is the memory device for that. I also want to talk about thalassemia. I didn't go into that too far last time. Thalassemia is a condition that can lead to microcytic anemia because it's part of the tails mnemonic. Thalassemia, anemia of chronic disease, iron deficiency, and then sideroblastic anemia includes lead poisoning, but lead poisoning is part of the tails mnemonic. So with thalassemia, you would see on x-ray, you'd see a crew cut appearance like on the skull, and we already saw that with sickle cell anemia, and that's just basically the body is trying to produce red blood cells, so it goes to unusual sources of bones to make that red blood cell, and they're hyperproliferative. So on x-ray, you'd see like a crew cut appearance is what it's called. And then for thalassemia, you'd see the crew cut appearance. On red blood cell smear, you would see a lot of nucleated red blood cells because those bones aren't as precise about making red blood cells, and you would also see target cells. And so there are different types of thalassemia. There can be alpha thalassemia or beta thalassemia, and there's minor and major. For alpha thalassemia, there are 2 genes on the chromosome 16. There's alpha 1 and alpha 2. And if you have alpha thalassemia, that's a whole gene deletion. So it deletes the entire alpha gene. And you can have a deletion of 1, 2, 3, or 4 of the genes. So you can have cis deletions, which they are both on the same chromosome, or you can have trans, which would be on different chromosomes. Cis deletions are more common in Asians, and it's more serious. It's a very severe thalassemia. The trans is seen more in Africa or African descent people, and that's a more minor thalassemia. So if you have 3 deletions, that would be called HB or hemoglobin H disease. And then if you have 4 deletions, that would be called hemoglobin Bart's disease. So if all 4 of your thalassemia, alpha 1s and alpha 2s, they're all deleted, you'd have hemoglobin Bart's disease, and that's fatal. It leads to high drops fetalis, and so the baby would have increased fluid, and you'd have stillbirth if it was delivered. Okay, so with beta thalassemia, that's on chromosome 11, and I remember that because chromosome 11 is like two 1s and 2 genes, and beta is the second 2. So with beta thalassemia, you would see elevated hemoglobin A2 or hemoglobin F, fetal hemoglobin, and that's the body's way of making up for the deletion of the regular hemoglobin. And then beta thalassemia is a point mutation versus alpha was the whole gene deletion. And you can have a minor and a major depending on if the person is heterozygous or homozygous for that. All right. And then megaloblastic anemia, I'll talk about that a little bit more, just macrocytic anemia in general. So megaloblastic anemia would be caused by like a B12 or folate deficiency, and those deficiencies can be caused by alcoholics because they have a decreased nutritional absorption, and certain medications such as methotrexate, sulfa drugs, trimethoprim, phenytoin. Phenytoin is a seizure medication, so if the question stem is talking about somebody who's on seizure medications, you think phenytoin, and then folate deficiency, and then the megaloblastic anemia. Megaloblastic anemia, so you're going to have macroerythrocytes on a blood smear, and it's due to DNA toxin, like with alcoholics, DNA toxin. So you're not going to have adequate DNA production. However, your RNA production isn't affected, so you're still going to have a lot of protein synthesis. And so when your red blood cell has a lot of protein synthesis, it needs somewhere for that to go, so it gets larger, and that's why you have that megaloblastic or macrocytic red blood cell. And specifically the DNA synthesis of pyrimidines and thiamide, because B12 and folate are both involved in the pathway to create those pyrimidines. Obviously A and G and T. So on blood smear, I've already talked about a little bit, they would be larger cells, and macroovalocytes would be seen. And then neutrophils would be hypersegmented. So that's one way to distinguish between megaloblastic anemia and just non-megaloblastic macrocytes. So if you see hypersegmented neutrophils, think megaloblastic, because the neutrophil is just megaloblastic. It's mega, it's super created in the neutrophils. And then specific symptoms or physical exam findings, you'd see glossitis and angular chelosis, so doing with the mouth. So B12 and folate deficiencies, you'd see an enlarged tongue, and it's not hypertrophied, it's just large, so they might describe it as glossy. and then chelosis, so like dry, cracked lips right here in the corners. So non-megaloblastic anemia is still macrocytic. You have large cells, so again, caused by alcohol, but not leading to the nutritional deficiency of B12 and folate this time, just because it itself is a DNA toxin. Liver disease, hypothyroidism, MDS, and Diamond-Blackfan would be seen more in children. Hypothyroidism, I think, like, you get larger if you have a hypothyroid because you don't have as fast of metabolism. So that's how I remember that it leads to macrocytic anemia. And like I already mentioned, you would not have hypersegmented neutrophils, such as with the megaloblastic anemia. So megaloblastic neutrophil nucleus, and then with regular macrocytic, you wouldn't have the hypersegmented. Sorry, I keep getting distracted by people walking by. And then, so alcohol is the most common cause of non-megaloblastic macrocytic anemia, and with that, you'll see round cells. So with megaloblastic, you see more ovalocytes, and then with alcohol non-megaloblastic anemia, you'd see round cells. And then also there's pernicious anemia, which is related to megaloblastic, because pernicious anemia, you have a B12 deficiency because you have an intrinsic factor deficiency, and you need that intrinsic factor in order to absorb your B12. And so the reason why you would have an intrinsic factor deficiency in pernicious anemia is because you have an autoimmune destruction of your gastric parietal cells, and your gastric parietal cells are the ones that secrete the intrinsic factor in your stomach. That intrinsic factor binds to the B12 and allows it to be absorbed in the intestine. So if you have autoimmune destruction of the gastric parietal cells, you'd have inability to absorb B12 and leading to megaloblastic anemia. So a touch more on G6PD deficiency. I know I already talked about that. I'm not sure if I mentioned it was X-linked recessive, and you can lead to abdominal and low back pain due to the toxicity to your kidneys. And the Heinz bodies that are associated with G6PD deficiency, those are actually denatured hemoglobin. So that's what you're seeing in the Heinz bodies. And again, that's due to like inefficient red blood cell creation. So they have these denatured hemoglobins in them, and the pancreas picks up on that, or the spleen picks up on that and takes bites out of them. So that's why they have the degmocyte red blood cells. That's what they're going for. So G6PD, the enzyme, helps reduce NADPH, and in turn maintains glutathione in a reduced state. So that's part of the pathway that helps you protect red blood cells against hydrogen peroxide, reactive oxygen species. So that's why deficiency in G6PD makes that pathway an inability to be able to reduce glutathione and then reduce the oxygen species. And some things that can lead to G6PD deficiency, anemic, what do you want to call it? Like an acute attack of it, primaquine, sulfa drugs, nitrofurantoin, aspirin, and dapsone can all lead to G6PD attack, I guess. And then with hereditary spherocytosis, I just wanted to hit home that it's aplastic anemia with parvo B19, which I know I mentioned, but I just wanted to hit home on that. And then with PNH, I mentioned all of these in the hemolysis video, but also I wanted to hit home the incidence of AML and MDS are increased with PNH. You have thrombophilia, aplastic anemia, I don't think I mentioned that, and then you diagnose it with the sucrose and the acidified serum test and cytology. Okay, now I'm going to talk a little bit about transfusions, blood transfusions. So if you have a clerical error and transfuse somebody with the wrong ABO type, which clerical error is preventable but is the most common cause of ABO incorrect transfusions, you'd have red blood cell destruction by complement, and that's intravascular hemolysis. And that's activated by IgM, which makes sense because your IgM is what gives you like your anti-carbohydrate red blood cell antigens. And then with Rh incompatible transfusion, so if an Rh negative person gets Rh positive blood, you'd have anti-D IgG against the Rh protein, and this is only after sensitization. So again, it's that D on the Rh that causes the biggest antigenic reaction. So certain bacteria products can cause hemolysis, the biggest being Clostridia perfringens. That's the most dramatic hemolysis creating bacteria. So Clostridia perfringens. And it's a gram-positive spore-forming bacteria, gram-positive spore-forming Clostridium perfringens. Type A specifically causes the worst problems. And it has an alpha toxin, which produces a double zone of hemolysis. So when you culture it, you can see it has a very active hemolysis. And it also has lecithinase, phospholipase C. It can mediate massive hemolysis, tissue destruction, hepatic toxicity, myocardial dysfunction. And something you'll see with Clostridium perfringens, if you try to do a blood smear with it, you won't see any white blood cells or platelets because it completely destroys them. It's very destructive. Another bacteria that can cause hemolysis is Haemophilus influenzae type B. So with Clostridia perfringens, it was type A, and with Haemophilus influenzae, it's type B. So Clostridium had alpha toxin and lecithinase, phospholipase C. So Clostridium starts with a C, phospholipase C, type A, alpha toxin. And then Haemophilus influenzae type B has polyribosomal ribosyl phosphate, or PRP. And that's released from the bacterial capsule, and it can coat RBC, and that causes an immune reaction to hemolyze those red blood cells. So switching over now to Plasmodium, it's intracellular, and it's spore-forming. It's obligate intracellular parasite. Unicellular pore-forming. It's vector spread, obviously, in Plasmodium malaria. And so after the mosquito feeds and is infected, it takes 9 to 17 days after that feeding for them to actually infect a new person. And then the trophozoite is the part of the life cycle of Plasmodium that actually infects, that is actually in the red blood cells and causing the pathologies because it's feeding off the hemoglobin for its nutrients. So trophozoites, that is the feeding stage of the life cycle. For prophylaxis of Plasmodium, you would use mefloquine and doxycycline. So it used to be chloroquine for treatment, but there is Plasmodium falciparum that's been found to have high resistance to chloroquine. So now you would use like a doxycycline plus a quinidine or quinine or melarone. And of course the doxycycline, because it's an obligate intracellular, and doxycycline is really good at those intracellular bugs. For chronic treatment, because we know that Vivax and Ovally can be stored in the liver for years and have chronic outbreaks, you would treat with primaquine. But you have to be careful and pre-screen those people for G6PD deficiency, because we already learned G6PD deficiency patients, if they're given certain drugs, can have an acute attack of hemolysis. So primaquine is one of those drugs. So if somebody has chronic plasmodium, you want to make sure that you screen before you treat them with primaquine, because if they have G6PD deficiency, that can cause an acute hemolysis. So now moving on to Anaplasma phagocytophilum. So that's under Anaplasma and then phagocytophilum. And that leads to human granulocytic anaplasmosis. It affects all the granulocytes, eosinophils, basophils, neutrophils. And that was in one other video, but I don't think I hit on the fact that it is known to cause peripheral neuropathies. So demyelinating polyneuropathy and facial palsy are two of the things that can be seen with Anaplasma phagocytophilum. And then Bacillus anthracis, anthrax. That's another one of the gram-positive rods, spore forming like Clostridium. So we talked about Clostridium. This is similar, gram-positive rod spore forming, Bacillus anthracis. It's very hardy. It has a really large, strong capsule, and it has a protective antigen called PA for protective antigen that keeps it from being destroyed by immune systems. So this protective antigen plus an edema factor is called the edema toxin, or ET, and that adenylate cyclase something. So the protective antigen plus the edema factor equals edema toxin, and it causes edema, obviously, by adenylate cyclase. So the protective antigen plus a lethal factor equals a lethal toxin, and the lethal toxin is obviously lethal via zinc metal protease. So what anthrax will do is stimulate pro-inflammatory cytokine release by macrophages, causing the edema and the immune reaction that's bad for you. And then you can treat with ciprofloxacin or doxycycline, and plus you want to do 1 or 2 other antibiotics. There is a vaccine available for this, and question stems will talk a lot about, could be like somebody with farm animals with sheep and stuff, or breathing it in. It's aerosolized, so bring it in, it's used for bioterrorism. Okay, switching gears. So we talked about terrorism. Now we're gonna go and have a nice vacation in Hawaii. And in Hawaii, you can get Leptospira. That's a very large incidence in Hawaii, especially by tourists. So Leptospira, they're obligate aerobes, and a lot of times they're found in water where there's a lot of high incidence of rodents. So they damage endothelial cells, and you can culture them under, they're a spirochete, and you can culture them, unlike some of the other spirochetes that are very hard or impossible to culture. But in order to culture them, they need a lot of extra things. So they need vitamins B12, B2, long-chain fatty acids, and ammonium salts. This is for Leptospira. And I said they damage the endothelial cells. That can lead to an overwhelming disease called Wheel syndrome. And Wheel syndrome is vascular collapse, thrombocytopenia, hemorrhage, hepatic and renal failure. And that's when it's an overwhelming. But the most commonly presents as septic meningitis. So these spirochetes penetrate the mucous membranes, so they aren't very good at penetrating like on the skin where there's keratinocytes, but they'll be able to penetrate like in your nose. And then your humoral immunity is the one that's going to be defending you against these for the clearance of Leptospira. And you would treat with penicillin or doxycycline. Next, I'm going to talk about schistosomiasis, or schistosomia. And this is another one that people can catch from being in the water, near the water. And it's associated with snails. That's the carrier. And then they'll leave the snail, and these cercariae will penetrate your skin. And it doesn't have to be mucous membranes. It can be anywhere. So they penetrate your skin, and you'll have a reaction where they penetrate your skin, and that's like considered the early reaction, and you'll get a pruritic rash at the site of the cercariae penetration for schistosomia. And so this little worm is in your body, and then it can cause Katayama syndrome, and that includes fever, chills, cough, urticaria, leukocytosis, eosinophilia, polyclonal gammopathy, splenomegaly, and abdominal pain. And the symptoms are they start at the onset of oviposition, so when the eggs are laid, and depending on where it is will affect the symptoms. And so you have an inflammatory response to the eggs. And then you have chronic symptoms, which would be granulomas and fibrosis. And that's your immune response to having those eggs in your body. The treatment for this is praziquantel, and that's all we need to know for this exam. Although there are other treatments, but we just need to know praziquantel for schistosomia. There are 3 types of schistosomias, and they are most distinguishable by their eggs. So 2 of them you're going to find coming out in feces because they affect the intestines, and then 1 affects the bladder, so you would see that in urine. So you have to test both urine and feces if you suspect schistosomias. So schistosomia mansoni and japanosome, those are both in the intestines. And I'll start with mansoni. So mansoni affects the colon. So mansoni, I think like mansion, it's a large house, so it affects the large intestine, the colon. And they also have a very large lateral spine. So you'll see a spine coming off the side of the egg. And they can lead to clay pipestem fibrosis because it is in the colon. It can cause clay pipestem fibrosis of the colon. And you'll also see hepatic and intestinal abnormalities because, again, it's in the intestinal system and can lead to myeloradiculopathy. Trypanosome, this also affects the intestines, but this is the small intestine. So trypanosome, however you say it, is a small island, I guess. So I associate that with it affects the small intestine, and also it has a small spine. So mansoni had a large spine, and trypanosome has a small spine on the lateral side, and it can also cause clay pipestem fibrosis and hepatic and intestinal abnormalities. So mansoni, trypanosome, those are in the intestines. And then the one that's in the bladder, which you would find the eggs in the urine, not the feces. So in the bladder, it's in the middle, and the bladder comes down like this and has, the urethra coming down through the middle and the terminal end of it. So that's how you can remember that the egg has a terminal spine in the middle, whereas the 2 intestinal ones had lateral spines. The hematobium has one in the center coming down, terminal, kind of like the urethra coming off the bladder. And this one you just kind of have to remember comes from the bladder. It has a large terminal spine, and it can cause urinary symptoms like hematuria, dysuria, and frequency. Again, schistomiasis, and you treat with praziquantel. Comes from snails. Schisto, snails, mansoni, hematobium, trypanosome, and treat with praziquantel. Okay, so again, back with transfusion. So you'd get your whole blood drawn, which would be about 450 mils, plus or minus 45. And it can be stored within 8 hours if you only have red blood cells at 1 to 6 degrees Celsius. And if you're only using it to make components, you can store it at 20 to 24 degrees Celsius. So if you're trying to distinguish if someone needs a transfusion, people with a low hemoglobin less than 10 without any symptoms, they rarely need transfusion. And then if they have hemoglobin less than 7 and it's chronic, they might not need it. But if it's an acute drop, then yes, you would transfuse for hemoglobin less than 7. For hemoglobin between 7 and 10, if they're symptomatic, you would transfuse despite euvolemia or CV disease. because you need to correct those symptoms. So a patient is given 1 unit of red blood cells, and for every 1 unit of blood cells, that will increase hemoglobin by 1 gram per deciliter. And it will increase hematocrit by 3%. So 1 unit of red blood cells, 1 gram of hemoglobin, 3% hematocrit rise per unit of blood. So some things you can do to the blood before transfusing into a person to decrease negative reactions. You can leukoreduct. One long reduction, a single reduction, is less than 5 times 10 to the 8th. The reduction of the glucose, and that prevents febrile transfusion reaction. So if you leukoreduce once, that can prevent febrile transfusion reactions. If you do 3 log reduction, so less than 5 times 10 to the 6th, that will prevent HVLA alloimmunization or CMV transmission. So 3 log reduction prevents HVLA alloimmunization or CMV transmission. Another thing you can do to the red blood cells before transfusing them is do gamma radiation to them. And the product is good for 28 days after gamma radiation. And this will prevent transfusion-associated graft versus host disease, or TAGVHD. So gamma radiate to prevent the graft versus host disease. You would also want to use gamma irradiation for anyone less than 1 year old receiving a transfusion. You would gamma irradiate. You can also do something called the red cell wash, and this is where you remove all of the plasma products and replace it with just normal saline and the red blood cells. And the product is only good for 24 hours after you do the red cell wash. This can prevent anaphylaxis in IgA deficient recipients because the plasma products contain that IgA. So if you wash the red blood cells, then the IgA is gone and they won't have a reaction to it. You can also do this for PNH patients. So the paroxysmal nocturnal hemolysis, you would want to do a red cell wash. If someone is getting platelets or you suspect they need platelets, so for someone getting neurosurgery, you would want to transfuse them with platelets because they have to be greater than 10,000 for neurosurgery. If they're undergoing just any other kind of invasive surgery, you want them to be at least greater than 50,000. And then if someone has a platelet count less than 10 to 20,000, you would transfuse platelets prophylactically because they're at risk of spontaneous bleeding. There are certain disease states where you wouldn't want to transfuse platelets, and we've talked about this before. So platelet transfusion is contraindicated in ITP, DIC, TTP, HIT, and hypersplenism. And we've talked about that because it would kind of be adding fuel to the fire for a lot of those. And platelets are good for 5 days. They're stored at room temperature. So now we'll talk about fresh frozen plasma. So that's just the plasma products of the blood, and those are frozen. And they're good for 1 year, stored at negative 18 degrees Celsius. But after you thaw them, they're only good for 24 hours. They contain coagulation factors in the fresh frozen plasma. So you would freeze to preserve the factors 5 and 8. 5 and 8 are the ones that you need to preserve so they don't disintegrate at room temperature. You would use this for DIC, liver failure, and reversal of Coumadin, just a rapid reversal, and TTP. So coagulation factors would be good for restoring in someone with DIC, liver failure, Coumadin overdose, and TTP. Or Coumadin, not necessarily overdose, but reaction. And then you have cryo. Cryo is also good for 1 year, stored at negative 18 degrees Celsius, and again, only good for 24 hours after thawing. So cryo, it's really important to know, contains fibrinogen, fibronectin, von Willebrand's factor, factor 8 and factor 13. So factor 8 and factor 13, von Willebrand factor, fibronectin, and fibrinogen are found in cryo. They would be used for treatment of DIC, factor 13 deficiency, factor 8 deficiency, and von Willebrand's disease. So it would make sense that you give factor 8 and factor 13 if they have a deficiency, and von Willebrand's factor for von Willebrand's disease, and also for DIC. You'd want fibrinogen, fibronectin, von Willebrand factor, factor 8, and factor 13. That's what's in cryo. Now we're going to talk about negative transfusion reactions. You can have reactions to the red blood cells, the plasma proteins, the leukocytes, the platelets, or just having like an overload. So different reactions to the red blood cells. You can have a delayed extravascular hemolysis, and this is when a patient has a reaction to the alloantibodies, such as the KID, KEL, Duffy, etc. parts of the red blood cell. And it happens days to weeks after the transfusion, and you have a fever. So if someone's getting a transfusion, you want to make sure you check their fever, and if they don't have any other explanation for it, these are some of the causes of that. So that was delayed extravascular hemolysis. You can also have acute intravascular hemolysis, and this is if you have a fatal ABO incompatibility. So this is the clerical error I was talking about. And again, you'd have a fever, and it's acute. It would happen right away, and it's fatal and preventable. You can have secondary hemochromatosis. There's a role of chelation in that, and basically that's just iron overload, so the body starts storing it in inappropriate places. You can have a reaction to plasma proteins due to IgE and IgA action, and that will lead to anaphylaxis as in a severe case, or you can also have just a mild allergic reaction to that, and it can be treated with antihistamines. You can have a reaction to the leukocytes. There are different reactions to those. You can have a febrile non-hemolytic treatment reaction, or FNHTR, and that's a temperature rise of 1 degree Celsius without other explanation, and it's due to the cytokines from the white blood cells. You can have transfusion-related acute lung injury, or TRALI. That'll happen 1 to 2 hours after the transfusion, and they'll have fever, tachycardia, and hypotension, and that is when the donor HLA bodies react with the recipient white blood cells. You'll see infiltrates on a chest x-ray, and this can help be prevented by using only male plasma, because males don't have as much of this HLAs, because women, like when they have children, are exposed to more things, and so they build up more of a resistance and an immune reaction. So with TRALI, you'll see infiltration in the lungs, but they won't respond to diuretics. This is in contrast to another one we'll learn about. So TRALI does not respond to diuretics. Okay, so another reaction you can have to leukocytes are graft versus host, and we talked about that already. That can be minimalized with gamma radiation and can prevent it. But if you have graft versus host treatment association with transfusion, it's because the lymphocytes will engraft in the marrow of a person, and this is an immunocompromised patient, and they will start mediating an attack against the host. Okay, so you can also have a reaction to the platelets, and this occurs because of differences between platelets. Some people have PLA1 negative, and so if they're PLA1 negative and you expose them to a PLA1 positive platelet, and this can happen via transfusion or pregnancy, then they'll create anti-PLA1 alloantibodies, and that will destroy all the platelets, both the donor and the recipient platelets. So they'll have an extreme profound thrombocytopenia 2 to 14 days after the platelet transfusion. So it's completely counterproductive. So you have to make sure to type the platelets if they're, and the recipient if they're PLA1 positive or negative. And then you have transfusion-associated circulatory overload, or TACO. This is my favorite. So this is a volume overload, and it can cause respiratory distress because of that volume overload, and backing up into the lungs. A lot of times it's associated with like cardiovascular diseases, so it backs up, but it will respond to diuretics. So that's the difference between TACO and trolley. So trolley affects the lungs but will not respond to diuretics. TACO affects the lungs, but it will respond well to diuretics. Trolley, no diuretics. TACO, yes, diuretics. Okay, so we're going to talk a little bit more about hematuria and the renal tubules. So red-pink urine. So you see red or pink urine, what can cause that? Well, it could be blood, it could be hemoglobin, it could be myoglobin. So you have to look at it microscopically to see it. Also, certain foods can cause a reddish colored urine. Blackberries, beets, and rhubarb are known to cause red urine. And then the drugs that can cause red urine are rifampin and pyridium. So pyridium and rifampin, red. Pyridium, rifampin, red. Now we're going to switch over to brown urine. Brown urine can also be caused by myoglobin and hemoglobin in the urine. And then the foods that lead to it are fava beans and aloe. So we've already talked about fava beans with G6PD deficiency causing that red dark urine with the ketchup bottle going over the hamburger. And then the medications that can cause brown or cola-colored urine are metronidazole, metrotinazole, and methocarbamol. So the two M's lead to the brown-colored, like the muddy-colored urine are caused by metronidazole and methocarbamol. All right, I have a little note here for, so glomerular filtration rate, GFR, is measured by creatinine or inulin because they're completely filtered out or excreted. And then renal plasma flow is measured by PAS. That is 100% excretion. It's not reabsorbed, it's not secreted, it's just completely excreted and filtered out. So the efferent, or the vein from the nephron, has 0 PAS in it. And so renal blood flow is renal plasma flow over 1 minus hematocrit. So you can use that as a calculation. Okay. So the glomerulus filter, we know, is the endothelial cells, first of all, in the vessel. And then they have a basement membrane, which has a negative charge, and that prevents the large molecules or the negatively charged proteins and things to go through. But I wanted to mention that the basement membrane contains type 4 collagen. Type 4 collagen in the basement membrane of the kidneys. Not sure how to remember that, but it's important because certain diseases that affect type 4 collagen will affect that basement membrane in the kidneys. And then, of course, you have the podocyte processes under that. So type 4 collagen in the basement membrane in the kidneys. Renal biopsy. So if you do a renal biopsy, you can do H&E, and that will just show you in general what it looks like. You can do a PAS stain, and that will show you the basement membrane and the capsule. You can do a JMS stain, and that will show you also the basement membrane. Congo red stain will show you amyloid, and then a von Casa stain of the kidneys will show you calcification. All right, so that's what the different stains can show you. Now we're going to talk about tubular secretion. So tubular secretion, what is secreted from the tube? I know that potassium and hydrogen are secreted, organic cations and anions are secreted, but I wanted to mention that tubular secretion, you secrete penicillin and diuretics. And then I want to talk about chloride in the proximal tubule. So chloride is reabsorbed transcellularly with antiporters. So transcellular, it's reabsorbed antiporter transcellular chloride. And we already talked about that with sodium absorption is opposite of hydrogen chloride. So that's an antiporter, and that's transcellular. But chloride also diffuses paracellularly, reabsorption. And so it's paracellular reabsorbs due to a leakage or concentration gradient. Now I want to talk about the types of RTA, or renal tubular acidosis. So like it says, you have a problem with the acid-base disturbances in the renal tubules. And I'm going to start with type 2 renal tubule acidosis because that is in the proximal tubule. It's an impaired reabsorption of bicarbonate in the proximal tubule. And so if you have impaired reabsorption of bicarb, then you're going to have, because of the defective hydrogen secretion, because it's a 1-for-1 type exchange. So if you have impaired bicarb reabsorption, you're going to have impaired hydrogen secretion. And this is due to mutations in both the sodium hydrogen exchanger and the sodium bicarb cotransporter. It can be caused by CA inhibitors or CA deficiency, Fanconi syndrome, because Fanconi just dumps everything into the ocean, and also low phosphate and osteomalacia. This will lead to metabolic acidosis, hypovolemia, and hypokalemia, because again, if you're losing your bicarb, you have an acidic environment, and acidic environments will lead to hypokalemia, hypovolemia, or metabolic acidosis, and then hypovolemia because everything's getting pumped out with Fanconi syndrome and things that would lead to type 2 RTA. And you'd have low phos and osteomalacia because of the low phos. So type 1 RTA happens in the distal tubules and the collecting ducts, and that's also due to impaired excretion of hydrogen because of the 1-for-1 exchange. In adults, it's due to autoimmune disorders is what you'll see it presenting with. And in children, it's a hereditary transport defect. So it's inherited in children, but if it doesn't present until later in life, it's autoimmune disease. And you'll have a severe non-anion gap metabolic acidosis. So if you see somebody with severe metabolic acidosis, but their anion gap is fine, then think type 1 RTA. If they have an anion gap, then there would be some other thing causing the acidosis. That's some other anions being added into the system, the mud piles mnemonic. So if they don't have anion gap, but they have severe metabolic acidosis, think type 1 RTA. Another thing with type 1 RTA, you would see a lot of kidney stones. So with type 2, see low phos and osteomalacia. With type 1, you'd see kidney stones. And type 4 RTA, you see it a lot in diabetics. So type 4, think diabetics. When you have a deficiency of aldosterone or an aldosterone resistance, and it will lead to a mild non-anion gap metabolic acidosis and prominent hyperkalemia. So if you have a diabetic patient and they have prominent hyperkalemia, and then they have metabolic acidosis, which is mild non-anion gap, you'd think type 4 RTA. And with diabetic ketoacidosis, you would think that they would have a larger anion gap because that is one of the things that causes it. So talking related to that, formation of new bicarb in the kidney. So we know that bicarb is excreted and absorbed from the kidney, but it also forms new bicarb. It happens in the proximal tubule, and this is because of bicarb is involved in the formation of ammonium, and ammonium is the largest source of excretion of acid in the urine. So if bicarb is like a byproduct of the creation of the ammonium, then creating an acidic urine is going to cause the creation of bicarb. So you have glutamine that is turned into two bicarbs plus two ammoniums. And so the bicarb gets reabsorbed and the ammonium gets excreted. And in the collecting tubule, you'll secrete the ammonium and the hydrogen. And one ammonium is excreted for one bicarb reabsorption. So it's a 1 for 1. So every ammonium you excrete, one bicarb is reabsorbed. And ammonium is usually excreted as ammonium chloride. So that combination, the ammonium and the chloride, comes out in the urine, and you don't measure the ammonium, you measure the chloride. So indirectly, you're measuring the ammonium or acidic level by measuring the chloride level in the urine. So I'll talk a little bit more about metabolic acidosis, which I have been talking about. Metabolic acidosis can be caused by CRF, diarrhea, diabetes mellitus, and aspirin overdose. So RTA type 1 and 4 can lead to metabolic acidosis. Type 1 is in the distal, and type 4 is due to hypoaldosteronism. And then if you have it with an anion gap, think mud piles. Methanol poisoning, uremia, diabetic ketoacidosis, formaldehyde, iron or isoniazide, lactic acidosis, ethylene glycol or salicylic acid or aspirin. And then for metabolic, one thing about aspirin. So aspirin can cause a metabolic acidosis with an anion gap, and it can also cause respiratory alkalosis at the same time because it increases respiration and you're going to be hyperventilating, so you'll have respiratory alkalosis as well as metabolic acidosis. So if you see metabolic acidosis with wide anion gap and respiratory alkalosis, that can help lead you to an aspirin overdose, especially if there's some type of clue in the history. And then a little bit about metabolic alkalosis. It can be caused by excessive aldosterone, prolonged vomiting, antacids, volume contraction, and overuse of diuretics. Volatile acids are considered volatile acids if they come from the complete metabolism of fat or carbohydrates. So fat and carbohydrates completely metabolized equals volatile acids. Fixed acids come from incomplete metabolism of fat and carbohydrates and also from protein metabolism. Compensation for metabolic acidosis. So if you have metabolic acidosis, you're going to compensate with your respiration. But for the calculation, to see if they're compensating, you would take the bicarb and see where that is below normal. So if normal is 8 to 12, then you would take it's 24. So if bicarb normal is 24, and for instance, if your bicarb is 6, so that's 18 below normal, and then you look at your CO2, so if your CO2 is like 17, then you would take however many bicarb below normal, so like 18, and you multiply it by 1.2, and this is for acidosis. For alkalosis, it would be 1.5, but for acidosis, the constant is 1.2, so you take 1.2 times the difference from normal, so 1.2 times 18 equals 22.6. And so that's the amount the CO2 should drop by to be compensated. So since CO2 in this case is 17, that's less than 22.6, so it is compensated. You can also look at the urine anion gap to get a clue if the kidneys are excreting acid enough. Not regularly done, I don't think, but another clue. So with the plasma anion gap, you take the sodium minus the anions, but in urine anion gap, you take sodium plus potassium minus the anion, which would be chloride, because chloride indirectly is the ammonium excretion measurement. So if it's positive, then it's not excreting acid properly because you don't have enough chloride being excreted and indirectly the acid. So if it's negative, then that's a good thing because you're excreting a lot of chloride, which means your kidneys are properly excreting acid. So you want the urine anion gap to be negative. So we're going to talk about one little snippet about potassium excretion. So we know that potassium, pretty much everything gets filtered out in the proximal tubule and reabsorbed there. Potassium is excreted in the distal tubule principal cells. So think principal cells, potassium. It's the principal cells that excrete the potassium in the distal tubule. And that's all about that. Okay, so I want to talk a little bit about treating a patient with hyperkalemia. So if someone comes in with acute hyperkalemia, that can really affect the heart and cause arrhythmias. So the first line treatment for dialysis patients with hyperkalemia, like if they missed a few of their appointments for dialysis, they're going to have that hyperkalemia. You'd first want to treat them with IV calcium gluconate, and that'll just help stabilize the heart cells. So that would be the first step. And then giving them insulin and dextrose would also help move that kalemia or potassium into the cells. So the ultimate treatment also would be hemodialysis and other meds to get recorrected. If you have hypokalemia by the lower GI loss, so lower GI loss, diarrhea, you can have hypokalemia, and that's not a renal potassium loss. So that's two ways you can lose potassium. But if you have hypokalemia by upper GI loss, and that would be by like a nasogastric sucking, that can lead to renal potassium wasting. So it is renal related, and it can lead to secondary hyperaldosteronism and potassium and bicarb loss in the kidney early in vomiting. So if someone has vomiting or nasogastric sucking, it can lead to hypokalemia via the kidneys. If they have hypokalemia by lower GI loss, like diarrhea, that's not a potassium loss. That's just through the GI system. Almost done. Okay, so now I'll talk about hypercalcemia, which I've been trying to say this whole time. There's certain things that can lead to hypercalcemia, and then there's certain ways to correct it or prevent it. So if you have hypercalcemia caused by increased excretion by the kidneys, you'd want to increase their volume and their sodium, because if they're excreting it more, increasing their volume and sodium would help you retain more. And you can also do this by administering loop diuretics. If they have hypercalcemia because of blocked PTH release, you would treat with calcimimetics because they activate the Cassar system. So let me think through that. So if you have hypercalcemia treatments, yeah, because high amounts of PTH would lead to hypercalcemia because reabsorption of the bones and increase of the alpha-1 hydroxylase in the kidney and increased absorption of calcium in the intestines. So you'd want to block the PTH release, and you do that with calcimimetics because that activates CASR. And so that signals your body to not release more PTH. If you have hypercalcemia, due to PTH or malignancy or whatever that's reabsorbing a lot of bone, and you want to block that bone resorption, you give her bisphosphates, because bisphosphates help protect the bones from being reabsorbed. If you have an increased 1-alpha hydroxylase, which also can be due to malignancy secreting that hormone, or just overactive from the kidney, you'd want to block that alpha-1 hydroxylase, and you would do this with ketoconazoles or glucocorticoids. So ketoconazoles and glucocorticoids will block the 1-alpha dehydroxylase synthesis. So if you have too much calcium and you want to stimulate calcium uptake into the bones because of the increased PTH reabsorbing the bones or whatever, and you want to redeposit that into the bones, you can administer calcitonin, which would do that. That was difficult to read. Okay. Now some signs of hypocalcemia. So if you have hypocalcemia, which could be due to decreased intake, increased excretion, decreased PTH, increased calcitonin, different logical things you can think of. It's intuitive if you know some basic biochemistry of the body. But with hypocalcemia, you would see Chvostek's sign, and that's when you would tap the face and the whole muscle would twinge. Trezau's sign, that's when you take a BP cuff, and after waiting a few minutes, the arm would start spasming. And then somebody with hypocalcemia would present with muscular weakness and oral paresthesias. Moving on to phosphorus. So phosphorus, shifting in and out of the cell. So things that would make it shift into the cell, if you have a lot of phosphorus, obviously it would shift into the cell. Cell formation causes it to do that. Alkalosis. So alkalosis causes phosphorus to go in, and insulin causes it to go in, and catecholamines causes it to go in. What causes it to come out? Cell destruction, obviously it would come out. Acidosis, it would come out, and lack of insulin. So, insulin shifts the phosphorus into the cell, and so lack of insulin would shift it out of the cell. And then acidosis shifts phosphorus out of the cell. So if you have hypophosphorus, that can be caused by increased renal loss, decreased absorption, or inadequate diet, which is pretty rare because phosphorus is coupled with protein, and people usually get enough of that with their protein intake. So if you have an inadequate diet, increased renal loss, or decreased absorption, it can lead to hypophosphorus. Also can refeeding syndrome. So refeeding syndrome, somebody who's been malabsorbed for a long time and then gets refed, that can cause like a mad rush of phosphorus into the cell and excretion due to the volume intake. So to break that down, somebody who has high risk of refeeding syndrome are, like, it was first seen in POWs who are like severely starved and malnourished for a long time, or alcoholics who are malnourished, different eating disorders, anorexia, bulimia, just starvation in general. And then you refeed them, so you have an increase in the volume, and so that would cause the kidneys to start excreting and working again. So you would excrete phosphorus, and then the glucose, like if you give them breads and whatever, and glucose, that causes it to go into the cell. So they would have a serum level of phosphorus drop because it wouldn't be in their serum. It'd go into the cell, it would be excreted. And then if they have hypophosphorus, That can lead to osteomalacia because that phosphorus is something needed to bind with calcium to create the bone. You'd have muscle weakness, altered mental status. You'd have impaired PLT function, platelet function, impaired phagocytosis, and impaired leukocyte chemotaxis. So someone with hypophosphorus would have a decreased immune system, and you would, if they have loss of phosphorus due to diarrhea, you would treat them with oral oral medication causes diarrhea. Okay, so if someone is hypophosphoric, then you can treat them with oral medication, but it's not very well tolerated, and so there's a lot of non-compliance with it because it causes diarrhea. Sorry. You can also treat them with IV phosphorus. That's with severe hypophosphorus, or if they can't tolerate the oral. But some symptoms would be rhabdomyolysis, hemolysis, and central nervous system symptoms. And with hyperphosphorus, that can be caused by excessive intake. One of those things would be, can you go away? No, go away, I'm recording. So some laxatives are very high in phosphorus. Or diet are high in phosphorus. That would cause excessive intake would cause that. Or you can have inadequate excretion. So with hyperphosphorus, you would see things like vascular deposition with calcium because the body needs somewhere for it to go, so it inappropriately deposits it in the vasculature, and that can accelerate atherosclerosis. You would treat by decreasing intake, so decreasing protein, which is a lot of times coupled with phosphorus intake, and there's no ways to make the kidneys excrete more phosphorus. We don't have a medication for that, but you can give a phosphorus binder in the digestive system that binds the phosphorus and excretes it that way, so decreased absorption of it. So there's this thing called tumor lysis syndrome, and that's when a patient with a malignancy and they have chemotherapy and they're destroying a lot of these tumors, you can develop AKI, or acute kidney disease, with increased hyperuricemia and or hyperphosphatemia. So you can get hyperphosphatemia from tumor lysis syndrome, and it follows a major cell death because of the treatment of neoplastic conditions. And that's pretty much it for now.